Well, welcome to the Women's Imaging session of the Head to Toe course. And my name is Genevieve Bennett. I am the Section Chief of Women's Imaging at NYU, and I will be moderating this session. You know, this is the first year that we decided to have a session especially devoted to women's imaging at the Head to Toe course. And this decision reflects the evolution of women's imaging as a subspecialty area of interest within radiology. Today's lectures will focus on pelvic imaging, including lectures on ultrasound, CT, and MRI. And tomorrow morning's session, which will be moderated by Dr. Hilda Toth, will focus on breast imaging. I believe that you will find that we have assembled a great group of speakers who will lecture on a wide variety of important topics in women's imaging, including both practical applications of already established techniques as well as some of the newer technological developments that have applications in women's imaging. Ultrasound and CT evaluation of acute gynecologic conditions. The learning objectives of this lecture are to review the ultrasound and CT findings in gynecologic disorders that cause acute pelvic pain, including abnormalities of the uterus and adnexa, as well as some postpartum and postsurgical complications. And throughout the lecture, I will be discussing the complementary roles of ultrasound and CT in the evaluation of these disorders. Well, I think that we would all agree that ultrasound serves as the first-line imaging modality of choice for the evaluation of most suspected acute disorders of the female pelvis. However, I think we also all appreciate the expanding role of CT in the assessment of the patient who presents with abdominal and pelvic pain. And many times the etiology of the patient's symptoms is uncertain. Is the right lower quadrant pain related to acute appendicitis, or perhaps an obstructing ureteral calculus, or is it related to pelvic inflammatory disease? So CT may become the initial imaging test that is performed. And so I think it's important for us to become familiar with the CT manifestations of these various acute gynecologic conditions. Also, sometimes ultrasound findings are equivocal and further information is necessary, so CT can be performed as a follow-up to ultrasound. Now, I know you've seen our protocol for multi-slice helical CT imaging of the abdomen and pelvis and other lectures in the head-to-toe course. So I'm not going to focus on that other than to say that before you perform a CT scan in any young woman of childbearing age, of course, you always have to remember to exclude the possibility of pregnancy. So let's start off then with a discussion of some abnormalities related to the uterus. And of course, here the most common disorder that we encounter is fibroids. And I think that we're all very familiar with the ultrasound appearance of fibroids, and these are usually a more chronic problem, presenting with problems such as menorrhagia or dysmenorrhea. But sometimes fibroids can present in the acute setting related to various problems such as degeneration or hemorrhage, infarction, which may be related to torsion, bleeding, which can be related sometimes to prolapse of a submucosal fibroid, the so-called aborting myoma. So here's an example of a patient, a 35-year-old woman, who presents to the emergency room with abdominal and pelvic pain. And I'm not sure why the image on the right has sort of a speckled appearance, but hopefully we can just look beyond that. Anyway, on physical examination, she was found to have a large abdominal and pelvic mass. And so that's why she was initially evaluated with CT. And what she had here are just multiple large subserosal and pedunculated fibroids, which had undergone extensive hemorrhagic degeneration. And you can see that these fibroids demonstrate decreased contrast enhancement relative to the liver parenchyma here, for instance. And there are some higher attenuation areas within them corresponding to areas of hemorrhage. Now, here's a 45-year-old woman who presents to the emergency room with acute onset of pelvic pain. And again, it really wasn't clear what was going on with this patient, so she was initially assessed with CT. And what the CT demonstrated was that she had this large lobulated mass located in the midline pelvis, which was superior and ventral to the uterus that we see back here. There was some associated pelvic ascites fluid, and neither normal ovary could be definitively delineated. And this is oftentimes the case with CT scan, where it can be difficult to identify the ovaries. Now, one take-home point that I want to make here and emphasize in the talk is that any time on CT you encounter a pelvic mass in a young woman who presents with pelvic pain, or any woman who presents with pelvic pain, you have to ask yourself, could this be related to the ovary, and could I be dealing with an ovarian torsion? And if you're not sure, you should follow up the CT scan with ultrasound assessment. And I'm going to be saying more about ovarian torsion a little bit later in the talk. So that was done here. The CT scan was followed up with ultrasound, and now we see the mass here, which is more complex on ultrasound. It has some cystic areas, some solid areas. Once again, it's located superior and above the level of the uterine fundus. We were able to identify 2 normal appearing ovaries here. So this was not an adnexal process. She was in a lot of pain, so she went to the OR, and this was a pedunculated fibroid, which had twisted on its vascular pedicle and had undergone infarction. Now here's a 38-year-old woman who presents with pelvic pain and vaginal bleeding, and I think appropriately the imaging test performed here was a pelvic ultrasound. And we can see on this transabdominal image that we have a hypoechoic mass in the area of the lower uterine segment and cervix, and when we put on color and spectral Doppler, we see that this has a feeding stalk or a vascular pedicle, which demonstrates arterial flow on this spectral tracing. When we perform the transvaginal examination, we see that this mass is actually prolapsing from the uterus down through the endocervical canal and into the upper portion of the vagina. And this was a large prolapsing submucosal fibroid, and this happens when you have a submucosal fibroid which is on a stalk and a vascular pedicle. Here's another example of a prolapsing submucosal fibroid as seen on CT. And you can see on the sagittal reformat the mass here, and it was initially felt that this could be a primary cervical mass, but I think this axial image is helpful because you can see that there's actually a little bit of air trapped between this mass and the wall of the cervix, which is kind of splayed around this mass. So this was actually another example of just a large prolapsing submucosal fibroid. So leaving fibroids now, moving on to endometritis. This problem usually occurs in the postpartum setting. It can be seen after instrumentation or in the setting of cervical stenosis. It's usually diagnosed on the basis of clinical grounds when you have a patient with an enlarged tender uterus and fever and elevated white blood cell count. But sometimes imaging can be helpful both to confirm the diagnosis as well as to look for associated complications such as gonadal vein septic thrombophlebitis. And here's what you might see on ultrasound. In this transvaginal image, we see that the uterine cavity is distended. It contains complex fluid and debris, and there's also a lot of gas present here. Now you have to remember to be careful because in the postpartum setting, you cannot make the diagnosis of endometritis just on the basis of gas present within the endometrial canal alone, because you can see gas in the endometrial cavity even up to several weeks after a normal delivery. Well, the CT findings of endometritis will parallel those at sonography. You will see a distended uterine cavity containing complex fluid. You may see some gas. And here we see some higher attenuation material. Now, unless you have the benefit of having pre and post contrast imaging, you're not going to be able to differentiate at CT whether this is just retained blood clot in a patient who's postpartum or if it's actually retained products of conception. And so what you need to do there then is, again, follow up the CT scan with an ultrasound. And with retained products, what you'll see is an echogenic mass present within the endometrial canal. But again, this could still represent retained blood clot. So we use color and spectral Doppler and show that there's actually a lot of vascularity associated with this, with a typical low resistance type arterial waveform, confirming that this is in fact retained products of conception. Here's a woman who's 6 days out from a C-section, and clinically she had endometritis, and the CT scan was done to look for an associated pelvic abscess. And you can see that she does have an abscess collection here in the left lower pelvis, and then she had this mottled collection of gas and fluid related to the uterus. And I think the sagittal reformatted image here is very helpful in showing you that this was actually an abscess collection which had formed at the site of the uterine incision related to the C-section. Leaving the uterus now and moving on to the ovary. So once again, the diagnosis that we don't want to miss here is that of ovarian torsion. This can occur in the absence of ovarian pathology, usually in children, whereas in adults, it's usually associated with a mass. And the most common mass to be associated with torsion is the mature cystic teratoma. Now, this can present a diagnostic challenge to the clinicians, and initially it may be unsuspected, but if the leading differential diagnostic consideration is ovarian torsion, then ultrasound, including color and spectral Doppler, are going to be your test of choice. So what will we see on a grayscale image in an ovary that's undergone torsion? Well, it will be enlarged. It will often appear hypoechoic because it is edematous, and the follicles are arranged in a peripheral distribution. Now, of course, you may not see any vascularity with color and spectral Doppler, or you may see a very abnormal arterial waveform, as we see here, where there's actually reversal of diastolic flow, indicating a very high resistance system. Now, one thing I want to caution you, though, to remember is that early on in the setting of torsion, you may see preserved vascularity, particularly arterial flow, and that's because of the dual arterial supply of the ovary. So let's see an example here. So here's a young woman who had had a prior right oophorectomy about 15 years prior to now, presenting to the emergency room with right lower quadrant pain. She underwent ultrasound evaluation, and we see that there is an enlarged ovary measuring over 8 centimeters within the right adnexa, and it has this complex cyst associated with it that looks like a hemorrhagic cyst. Now, when we interrogate this ovary with the color and spectral Doppler, we are able to demonstrate, I think, a normal-looking arterial waveform here. But once again, look at the grayscale appearance of this ovary here. It's enlarged, it appears edematous, we see peripheral follicles. The patient was in a lot of pain, and also this ovary was located on the right, and she had supposedly already undergone a right oophorectomy, so we were concerned this was actually the left ovary that had rotated into the right lower quadrant. So she went to surgery, and this was confirmed as a left ovarian torsion, which was associated with a hemorrhagic cyst, and fortunately the ovary was viable. Now, again, we don't perform CT as the primary assessment to evaluate for potential ovarian torsion, but as I mentioned, sometimes this diagnosis is unsuspected and CT may be the first study performed. And I think there are some findings that you can see at CT that can tip you off to or heighten your suspicion for the diagnosis of ovarian torsion, and many of these findings parallel those that you'll see at sonography. So you may see an enlarged ovary with peripheral follicles with or without a cyst or mass. The process may be located high in the pelvis, located anterior and superior to the uterine fundus. You may see surrounding inflammatory change and fluid. If there is lack of contrast enhancement, then that indicates that the ovary has already undergone infarction. You may see a pulling or a deviation of the uterus to the side of the twist, engorgement and congestion of the vascular pedicle, which may demonstrate a beaked configuration at the site of the twist, and you may see a thickened fallopian tube. Now, here's a woman who was imaged with CT on this day, and the clinical problem here was she was postpartum, had endometritis, and the clinicians were looking to rule out a pelvic abscess. Well, she did not have a pelvic abscess, but she did have this cystic mass in the left adnexa, which looked complex with some areas of septation in it, and it was felt that this was probably a cystic ovarian neoplasm, and she was scheduled to return at a later date to have this removed electively. Well, about a week later now, she presents with right lower quadrant pain, and a CT scan was performed because the diagnosis of acute appendicitis was considered. Now we see that this mass has rotated into the right lower quadrant. We see that it is associated with this tubular structure, which represents the congested and edematous fallopian tube, and this was an ovarian torsion associated with a mucinous cystadenoma. Here's a patient with a torsion associated with a serous cystadenoma. Again, we see this large cystic mass. It's related to the ovary, which is also enlarged and has peripheral follicles and sort of an edematous appearance. There are surrounding inflammatory changes, and this process is located above the level of the uterine fundus. Here's a patient who had had a dermoid removed from the right ovary 3 weeks prior to now presenting to the emergency room with pelvic pain and fever. And here a CT scan was performed because the possibility of a postoperative abscess was considered. And here what we see is the enlarged right ovary, which is demonstrating decreased enhancement. Note again how it is located anterior to the uterus, and it's associated with this serpiginous enhancing structure, which is the engorged distended vascular pedicle. And unfortunately, at the time of surgery, this was confirmed as a torsion, and the ovary was not salvageable and had already undergone infarction. Now, we're doing a lot of renal stone protocol CT scans in our department to look, without oral and IV contrast, to look for ureteral calculi. And this is a 28-year-old woman who presents with abdominal and pelvic pain for a renal stone CT to rule out ureteral calculus. Well, she did not have a ureteral calculus. What she did have was this large complex mass within the pelvis. We can see it has a fat fluid level. It has some calcium in it, very typical for a dermoid. She was in a lot of pain. You have to worry about the possibility of torsion. She went directly to surgery, and torsion was confirmed in the OR. I just wanted to briefly mention that myself and one of my fellows, Dr. Wendy Horn, in collaboration with Dr. Munias at Mallinckrodt, we recently reviewed the CT findings in 20 patients with confirmed adnexal torsion, and we submitted this as an abstract for the Rankin-Ray meeting. The most frequent CT findings we saw were an adnexal mass located above the level of the uterine fundus with associated fallopian tube thickening, ascites, pelvic inflammatory changes, and inability to visualize a normal ipsilateral ovary. Now here's a 30-year-old woman who comes in with left flank pain again, and so she had a renal stone protocol CT to look for ureteral calculus. Well, she didn't have a ureteral calculus, but she has this left adnexal mass, and it's pretty difficult to say anything more about this on this non-contrast CT. So she underwent ultrasound assessment. And what we see now is that this corresponds to this complex cystic structure, which has these fine, thin septations within it. There was no flow demonstrated internally, but there was vascularity in the wall of this. And this is, of course, a very typical ultrasound appearance of a hemorrhagic ovarian cyst. And what we would suggest is that the patient should undergo follow-up ultrasound to confirm resolution. Well, sometimes a hemorrhagic ovarian cyst can rupture and present in a very dramatic fashion with abrupt onset of pelvic pain and associated hemoperitoneum and hypotension. And this can be very severe and life-threatening in patients in particular who are undergoing anticoagulant therapy. Now, this usually involves hemorrhage into a corpus luteal cyst because these are very vascular structures, and we're familiar with this sort of ring of fire appearance that we see at color Doppler sonography, where we see circumferential flow in the wall of the cyst. And here's a CT correlate to that, which we see many times also when we see this rim-enhancing cystic structure. Now, at sonography, a ruptured hemorrhagic ovarian cyst may appear as just a large blood clot in the adnexa associated with complex fluid consistent with hemoperitoneum. On CT, you may see a high attenuation adnexal mass with a fluid level with a high attenuation dependent component because of the layering and hematocrit effect. If you give IV contrast, even though the cyst has ruptured, you still may see enhancement in the wall of the cyst and a remnant of the cyst, and you can identify it. And also, if there's active bleeding at the time of scanning, you'll actually see pooling of contrast correlating with active contrast extravasation. And of course, this is going to be associated with a variable amount of hemoperitoneum. Here's another patient with a ruptured hemorrhagic ovarian cyst. We see this large clot in the right adnexa, the so-called sentinel clot. And then if we look very carefully, we will be able to delineate this remnant of the cyst that ruptured with some enhancement in the wall. And we see that there is blood in the paracolic gutters. Endometriosis is usually a more chronic problem, and sonography is excellent for characterizing a mass as an endometrioma when we see this characteristic appearance with homogeneous low-level echoes. CT appearance of endometriomas is very nonspecific. However, you may think about it if you see complex cystic adnexal masses and the process is bilateral, because it would be very unusual for, let's say, a hemorrhagic cyst to be bilateral. But I wanted to show you some examples on CT where endometriosis presented with a more acute problem. So here we have a patient with a small bowel obstruction. She has multiple dilated fluid-filled loops of small bowel. And at the point of transition, we see this enhancing soft tissue mass. Now, if you were to look at this, you'd have to consider the possibility of maybe a primary or metastatic small bowel neoplasm. This patient did have a history of pelvic endometriosis, and this was confirmed as an endometriotic implant at the time of surgery. Now, if there's an endometriotic implant at the base of the appendix, this can be a cause of acute appendicitis. And I think it would be difficult to make that call prospectively here, but you might think about it when you see that this patient also has bilateral complex cystic adnexal masses. In a more chronic situation, an endometriotic implant can lead to mucocele formation, as we see here. It's very unusual for an endometrioma to rupture and hemorrhage, but sometimes they can. Here's a patient who came in and clearly had a hemorrhagic process here related to the left adnexa. It was associated with hemoperitoneum. It wasn't certain if this was a ruptured hemorrhagic cyst or maybe an ovarian mass that had undergone torsion and hemorrhagic infarction, but at surgery this was confirmed as a ruptured endometrioma. Sometimes you'll encounter an implant of endometriosis in the abdominal wall. This usually occurs adjacent to a surgical scar or incision because there's a mechanical transplantation of endometrial cells. It can also occur along the tract of an amniocentesis needle. And this will appear as an enhancing soft tissue mass that may be confined to the rectus muscle or may be extending into the subcutaneous fat, as we see here. And you should think about this if you see an abnormality such as this in a female patient, and if you note that it's adjacent to a surgical scar or perhaps a trocar site related to a laparoscopy. And sometimes the patient will give a history of a cyclical symptoms related to this mass. Sometimes clinically this is mistaken for a periincisional hernia because it's a painful, palpable lump next to a surgical scar. Other things you might think about just based on the imaging appearance would include abdominal wall masses such as a desmoid tumor or maybe metastatic disease if the patient had a known primary, and also in the right clinical setting maybe even a hematoma. And these have to be resected in their entirety, otherwise they have a high likelihood of recurrence. Pelvic inflammatory disease is a continuum from endometritis to pyosalpinx to tubo-ovarian complex, and lastly to the end result, which is tubo-ovarian abscess when there's complete loss of architecture of the normal adnexal structures. What we'll see with a pyosalpinx is a distended fallopian tube filled with complex fluid with thickening of the wall as well as the endosalpingeal folds, and on cross-section this will appear as this cogwheel appearance. Tubo-ovarian abscesses are usually bilateral and they appear as complex, multiloculated masses with thick septations and oftentimes with fluid debris levels. Well, on CT, you may identify a pyosalpinx as a distended fluid-filled structure, and if you look carefully, you will identify these little mural nodular excrescences, which correlate to the ultrasound findings of these endosalpingeal folds and this cogwheel appearance. And that feature can be helpful because if this process is on the right side, it can be difficult to differentiate from acute appendicitis because this will also appear as a tubular fluid-filled structure. And in this patient, the inflamed appendix is interposed between the ovary and the uterus. And so it was a little bit of a diagnostic challenge, but if you follow that over sequential images, you'll see that it arises from the base of the cecum, where there is also associated soft tissue inflammatory thickening, the so-called cecal bar sign. Now, it is possible to make the diagnosis of acute appendicitis, as we all know, on ultrasound, and also on transvaginal ultrasound. If you perform a study and you see a normal right ovary, as we have here, but the patient's complaining of right lower quadrant pain, look and see if you can find the appendix, which will appear as a distended, blind-ending structure, which is non-compressible and non-peristalsing. Acute appendicitis was called here, but the surgeons required a confirmatory CT scan before they took the patient to the OR, and here we see the CT correlate. Tubo-ovarian abscesses on CT, again, usually bilateral. They're complex cystic masses. If you look carefully again, you may be able to see these endosalpingeal folds. And I think performing off-axial reformatted images can sometimes be helpful in this setting to delineate the tubular nature of the process. One atypical organism you might encounter is actinomycosis. This is usually seen in the setting of a foreign body, such as an IUD. And the problem here is that this leads to a very dense fibrotic and inflammatory infiltrate, as we see in this patient, which may mimic carcinomatosis. But the tip-off here, in addition to these bilateral tubo-ovarian abscesses, is that we do in fact have an IUD here. So you should think about actinomycosis. TB is another organism which occasionally can be associated with pelvic inflammatory disease. The fallopian tubes and endometriums are the most common site of involvement, and this is usually a more chronic process, and the patient may present with infertility. Also, this can be associated with a tuberculous peritonitis, as in this patient where we see the TOA, we see thickening of the peritoneal reflection. There's also some nodularity, and so this could be mistaken for carcinomatosis. The patient went to laparoscopy and TB was confirmed here, and this is what her chest CT looked like with biapical cavitating nodules. So lastly then, in the last couple of minutes, I just want to talk about some postoperative and postpartum complications, starting with ovarian vein thrombosis and thrombophlebitis. This is reported as complicating about 1 in 600 pregnancies. It is more common in the postpartum setting, likely related to increased circulating levels of clotting factors, as well as compression of the veins by the enlarged gravid uterus. It can, however, be seen in the setting of pelvic inflammatory disease and also after pelvic surgery. Now, there is a predilection for right-sided involvement, and about 80% of the time, this will affect the right gonadal vein, and that probably has to do with the fact of the different anatomy of the right versus left gonadal vein, as we see on this Netter diagram. So the right gonadal vein drains into the IVC below the right renal vein, whereas the left gonadal vein drains into the left renal vein. So on the left side, you can have retrograde flow of blood down the left gonadal vein from the renal vein, which helps to prevent venous stasis. So CT or MR are going to be more sensitive than ultrasound in making this diagnosis, and what you're going to look for is an intraluminal filling defect within the distended gonadal vein, which is located ventral to the psoas muscle, and in this patient it has extended to the level of the IVC. If left untreated, it may propagate and cause septic pulmonary emboli. Here's another patient who had endometritis, and we see that she has clot in the right gonadal vein. Now, sometimes it can be difficult if you're not sure what you're looking at is just flow artifact in the vein versus a true intraluminal thrombus. I think delayed images might be helpful in that setting, and here we see in this patient on delayed scans there were thrombi present in both gonadal veins. Also, don't fall into the pitfall of mistaking a thrombosed gonadal vein for a dilated ureter, because both of these will appear as tubular structures with central low attenuation. So again, if you're not sure, go ahead and do delayed scans, and we see that there is filling in of the ureters here on the delayed scan. Now, fortunately, uterine rupture is very rare, and it's usually associated with procedures such as DNC. But here's a patient who presented for pregnancy induction, and she had had a prior history of uterine surgery. She had had myomectomy, and presented with a lot of abdominal and pelvic pain. And what we see here is that the fetus and the amniotic sac have actually been extruded and are located within the peritoneal cavity, and this was the site of the rupture of the uterus right here. This was suspected based on an ultrasound that the obstetricians had performed, but before they took the patient to the OR, they wanted a confirmatory CT. So it's kind of an unusual case that we see here. After a C-section, I've already shown you a case of an endometritis associated with an abscess. There can also be dehiscence at the site of the uterine scar, as we see here, where we see fluid and some gas in the endometrial cavity. We see that there is fluid now in the area of the scar, which is in communication with this large gas and fluid-containing collection within the pelvis, consistent with a large pelvic abscess. And I just wanted to finish up with this case, which again is something that's unusual that we don't see many times. This was a young woman who presented to the emergency room with a history of right lower quadrant pain. So the CT scan was done to rule out acute appendicitis. Well, she didn't have an acute appendicitis, but she did have these inflammatory changes within the pelvis. The whole pelvis just sort of looked kind of hazy. It was difficult to define the ovaries, but they seemed to be here. There was some fluid down in the cul-de-sac. And then if you look carefully, we see that there is this mottled collection of gas down here in the cul-de-sac, sort of in the area of the vaginal apex. And we thought, well, maybe this is a manifestation of pelvic inflammatory disease. Maybe this is a developing abscess. So she went to laparoscopy, and this gas was actually related to a vaginal laceration, which had been overlooked at the time of the physical exam. So if you see funny looking collections of gas or gas bubbles down there in the region of the vaginal apex, think about the possibility of a vaginal tear or laceration. So in summary then, although I think we will continue to rely on ultrasound as the first-line modality of choice for the assessment of the acute female pelvis, hopefully I've shown you that CT can also be a very helpful diagnostic tool in this setting. Many gynecologic disorders will have characteristic findings on CT, and if we are familiar with these, then we can allow prompt and appropriate patient treatment and also maybe eliminate the need for other imaging procedures.